Okay, so tonight's presentation is a presentation, something similar to it that I did for some patients recently, and they are cancer patients. And what I got was very positive feedback because it was understandable to them. As most people who don't understand the science behind COVID and the vaccines do appreciate this kind of thing. And I actually learned myself a lot by just preparing for this talk. So what I decided to do is, if it was good for lay people, I think we should share it with everyone. And I put some more data for you because you're in the more scientific world. But I think this is a mixture between what out there in the public, what people need to hear, and also we in the medical field. So my topic is, what does COVID-19 pandemic mean for immunocompromised patients? Because why are we making this big stint from the beginning? Since the beginning of COVID, I've been doing these town hall meetings every month, telling everyone, you guys wear the masks and wear the gowns and do the vaccines. And it's because we are, it's because, of course, we need to be safe ourselves, but it's because we're serving a very special patient population. In the first round around, when the vaccines first came, they did this over 65 years of people to be vaccinated first. I really fought hard to get the immunocompromised patients to be prioritized. I even, as a board member from the Washington State Medical Oncology Society, sent a letter to the governor on behalf of our society. And we were never being on the top as far as priorities for our patients. But this time around, everyone realizes there is a difference for these patients compared to lay people. And regardless of age, regardless of other multiple comorbidities, immunocompromised patients are a different patient population. So today's introduction, after introduction, what SARS is and some things that you probably know, I'm going to really go into the variants and vaccines, and then finish with the immunocompromised people. So I just will start with this. You already learned this, know this, but just say that this is a SARS-CoV-2. We had a SARS-1. We learned a lot from it. It's a member of a large family of viruses called coronaviruses. And these viruses can infect people and some animals. And it's actually first found in 2019, not 2020. And it's all coming out, as you know. But the most important piece, we were washing all the grocery boxes and hands and everything, which is still important to keep clean and to keep social, but it is a respiratory virus. So when we go to the hospitals, when we have a respiratory virus like chickenpox, we wear the gowns and the masks, and this is not new to medical community. In the hospitals, that's what we've done for years. So this virus is a respiratory virus. That's why we have to protect ourselves with the masks. This is the COVID-19 status as of, I got these numbers renewed last night. US, if you look at different websites, this was from WHO. US number is 40,345,484 total cases. The upper number in red is the world cases, 223 million plus. Total deaths is 4.6 million in the world and 650,000 in the United States. So these are the known variants, and actually there's more known variants than this, as you all are gathering from what's being presented out there. But these are the important ones because these are the ones relevant to the vaccine and everything that we're doing right now. And they were more prominent, more dominant in the areas that they started and then invaded our country and other countries in the world. Started with the United Kingdom, Alpha variant, B117. Beta was from South Africa. You heard about that one pretty much. And Brazil was Gamma. And then the Delta happened in India. I'll talk a little bit more about Delta later, but this graph shows you, this is as of August 21st. So I have even more recent data, but I didn't put it there. I thought, 10 days, whatever, it's not even 10 days, 2 weeks apart now. But it pretty much shows that in May, in our country, in the US, a Delta variant was very, very small amount, at least what was known. But B117 that came from England, which is the Alpha variant, was the dominant one. And then as you see here, by now, majority of the cases are the Delta form. And when you look at the Delta variant, B16172, how it's described is those spike protein mutations. Those are every new virus will come with mutations, and usually coronaviruses have 1 to 2 mutations a month, but sometimes it can be, in this particular one, the mutations are going extremely fast, 17 to 23 times a month. So new mutations are occurring as we speak, and this is why there are probably all letters of the Latin alphabet is occupied by different variants and beyond. But this one is important. First identified in December 2020, and we heard all about the India. Actually, not in Great Britain. It went to Great Britain, and then it came to all over the world. And who knows, actually, by the time it reached Great Britain, it probably reached everywhere in the world. It's just the identification of it. By the end of August, it is more than 90% of the cases. In fact, in some areas, I'll show you that 99% of the cases in the US. Well, this was an important variant because July 4th weekend, there was a big gathering in Provincetown, Massachusetts. Cluster of 470 cases were found that were infected. And what was surprising about this, 3/4 of those cases were vaccinated. 61 deaths, and they were mostly unvaccinated. The vaccinated cases, even without symptoms, had loads of virus in the mouth and nose. This is why they actually make the analogy of this virus to chickenpox, where you go out there, you don't have you're not wearing a mask, or even with the mask, if it's not properly done, the exposure rate is extremely high, and exposure possibility to this virus is extremely high, and it is like chickenpox in that sense. So it is definitely more contagious. Alpha variant, the one that was discovered in Britain, was 50% more contagious than the original strain. This one is 50% more contagious than Alpha. And if you look at the original strain, this was done in epidemiologic studies. CDC reported this earlier. If you're in a place with no mask, one person can infect two people can infect four. They did all these models. Delta variant infects 3 to 4. So it's 2 times more many infections than the original one. So the other thing, it is in unvaccinated patients, especially, can cause a more severe, this is being still studied, but that's what's being suspected, more severe illness than the previous variants. And unvaccinated people, therefore, remain as a greatest concern. And our hospital sends us very frequent correspondence on the status of the hospitals. All multi-care hospitals, we're closer in Puyallup to Good Sam. Multi-care, Franciscans are doing the same thing. And we know at Good Sam, one of our biggest hospitals we serve, there is now a tent outside the emergency room, because the emergency room has 80 to 100 cases, some of whom are being treated under ICU care in the emergency room because there are simply no hospital beds. And this situation is more serious than the first one, because we never ran out of BiPAP machines, but this time they are actually running out of BiPAP machines. So again, fully vaccinated people like us, most of us, almost all of us are vaccinated at Northwest. With Delta variant, breakthrough infections and can spread the virus to the others. Probably this is the most important sentence of all the presentation, what we represent for our patients, because our patients, if they are vaccinated, they can still get the infection from us. And the only good thing about it, vaccinated people have much less serious, you'll see data later, but they also have a shorter period of time to disseminate the virus. Therefore, still it is important for us to know that and have a little bit comfort, but not get relaxed about it. Here it is. This is 8/21 nowcast, August 21st. In average, it's 99%, somewhere around that in all over the country. Pacific Northwest, the number for Delta is 98.7%. Let's talk a little bit about the immune system. So a lot of whatever, I couldn't say it right. Let me say it again. Everybody knows something about the immune system these days. And people are experts about it. We in medical fields, we learned about the immune system, but it's still very complicated for even physicians and APPs and nurses and medical personnel, because immune system is extremely, as you know, complicated. But it is not just the B cells making antibodies, but it's also T cells. And it's almost like the New York metro system, where the immunity works in this very convoluted ways to initiate a response, the body responding to an outside virus or any other infectious source. So antibodies, when they are produced with IgMs and switch to IgG binding antibodies, and then there are some neutralizing antibodies. This is all in CDC. You can, if you have special interest, you can go and try to look at all this diagram and try to sort it out, how the antigen is being presented to T cells and B cells, what they do with the antibodies, and how some of the T cells, it's a mix of responses that our bodies do. So then how does a vaccine work? Well, vaccines contain either weakened or inactive parts of a particular organism. It's a virus or bacteria. It's called antigen. It's something from outside that triggers an immune system within the body. So the newer vaccines are even more sophisticated, not like the mRNA vaccines, because they do have the blueprint of this virus rather than real antigen in that vector that it is being given to the body. But regardless, one of the misconceptions are patients ask us, oh, I'm going to get the virus. Oh, I hear that when you get the vaccine, you get the disease. No, none of the viruses, none of the vaccines have strong enough, even in the weakened vaccines, the type of vaccines we used to give it with shingles vaccines or other attenuated live virus vaccines, none of it is strong enough to initiate a disease, but rather a response to the disease. So the vaccine types, very briefly, there is the whole microbe approach, there is the subunit approach, and then there is the genetic approach, nucleic acid vaccine. So if you look at this little pictures here, using a whole virus or bacterium, that will initiate either in an inactivated form or very, very attenuated, weakened life form. Examples, inactivated one is polio and flu. That gives the whole virus, or, you know, in this case, virus. Attenuated live is a very good example of this: chickenpox, MMR, measles, mumps and rubella, and shingles. Shingles now is having the inactivated one. That's the Shingrix one. The subunit approach is just a part of the virus. Most of the childhood vaccines are like that. And the genetic approach is the newer approach that actually had been going on at least 10 years before COVID came into the picture. And that's the one that we gave at Pfizer and Moderna today. So, but this is how vaccines work. This is where I get really, this is what I break. When patients tell me, oh, I'm okay, I won't take the vaccine because my immune system is good, and I don't think and that's my choice. My immune system is good, I'm gonna fight this myself. Well, unfortunately, a vaccine, especially in the middle of a pandemic, does not work individual by individual. It protects an individual, that's true, but it only will eradicate the disease if a community can get the vaccine, so that there are those rare cases where the people who cannot be vaccinated for 2 reasons, which is the only way that we will give an exemption, medical exemption letter to anybody, is if they have an anaphylactic or severe allergic reaction to a vaccine before. No other medical reason not to give the vaccine. But if you have a condition like it, or a small child, the way that the vaccines will eradicate the disease by everybody participating in the vaccination. So here is some, this is how it works in the normal traditional ways. This is really vaccine development takes 15, 20 years because you have the basic science, then animal studies that takes 8 to 10 years. Then you have to have 4 clinical trials in the traditional old ways. We used to spend 4 to 7 years. Then there is FDA and other approval processes, and then the manufacturing. So it takes a long time. But vaccine development in 2020, when the COVID hit us, had a lot of advantages. what happened is that there are different vaccines. For example, Janssen or Johnson and Johnson, that's the vector technology, had been previously studied in HIV vaccines and had been approved with the Ebola vaccine. So it wasn't something people had to sit down and think for years to develop that. There was a technology already present. There was mRNA vaccines, clinical and preclinical research already had happened, like I indicated before. And none of them were approved yet. The people worked on it though. There was experience with the protein subunit vaccines with the Hep B and meningococcus. And there was also technologies ready to move forward quickly and adaptable to the novel virus. And very importantly, SARS-1, this is SARS-2, if you remember, SARS-1 was the virus where it was so bad. And the only reason it got eradicated or got under control is because it was very easy to notice it compared to COVID-2 or COVID-19, because it was it has sometimes a long period before, or sometimes most of the time it's even asymptomatic. So that was the difference. But at that time, when SARS-1 came, they identified the spike protein. They knew how to purify it. So when SARS-2 came, it was a matter of weeks for the scientists to purify the spike protein and apply in the mRNA vaccine. So two different companies, two different worlds worked on it at the same time. So therefore, basic science was pre-existing. Animal studies didn't take too long because it was already bam, bam, baga, bam there. And then clinical trials, we have now, Sarah Sandifer is there. I'm sure Patty is there. I don't see her picture, but we in research world are very different from 20 years ago, how we did research. The statisticians come with certain numbers before doing a research on how many cases you need to make as meaningful results. And that was studied within months. We were so lucky to have a virus that was there, but the vaccine ready for it within months. Well, here are some examples. We don't have all of them. Vector vaccines, mRNA vaccines, subunit vaccines, killed virus vaccines all over the world, different countries, different places. Everybody is working on these. We have the three of the vaccines, Janssen or Johnson and Johnson as known, and the two of the mRNA vaccines, Moderna and Pfizer one, BioNTech. So this is their trial data. As you see, J&J, just one shot, had about 66.9% response, effectiveness. In severe, reducing the severe cases was 76.7% in 14 days. And when you waited for 28 days, it was 85.4%. It was preventing severe cases. There was one death out of 6.8 million people at the time when that happened, that received the vaccine, because out of that 6.8 million people who received it, 7 people developed blood clots. So it's known as 7 blood clots in 1 million and 1 death. But Moderna and Pfizer had 0 blood clots and 0 deaths. Although there were a lot of different side effects, allergic reactions. Some of my partners had severe joint aches and body aches and felt extremely fatigued. I felt fatigue, and some of you had some of you I know had some severe allergic reactions, but none of us had in our practice, or the people that we gave the vaccine had an anaphylactic reaction that we had to use the EpiPen. That's the reason why not to take it next time, actually. So very, very effective vaccines. Therefore, August 2021, Pfizer now is fully approved by FDA. At this point, 91% effective at preventing COVID-19 and provides strong protection against the serious illness. 0 death in the vaccine arm even now. And we now have 160-some million people in America and many in the world taking this vaccine, where we know the real world data. That's how the modern research happens. You go back and you have the synthetic control arms and look at the fresh data coming in and get every single side effect that happened, and they keep track of them. This is why some people have some transient inflammation in the heart, especially young people, but it's transient and it's mild. Nobody died and it goes away. My daughter, one of my daughters, developed a huge lymph node both times after she got it, and a lot of people develop it because you get some allergic reactions. So vaccinations for variants is one of the things I want to talk about. These are effective, but when it first came on, people said, well, I don't want to wear a mask because I'm vaccinated. First of all, no vaccine is 100% effective. As good as Pfizer and Moderna as the modern vaccines, no vaccine is 100% effective. That's bottom line. But there is also another problem. The new variants are complicating the situation. They are not responding to the virus. I have other slides I'm not showing here, but there is some data on how the Alpha variant and the South African especially did not have great responses, but people did not die from the COVID, and people had much less severe outcomes if they were vaccinated. Up to this point, all these variants, we know that's the case. Now, the future, but I'm much worried about, I'm not sure what's going to happen with the next mutation. It may not respond to what we have, but we'll talk about it. So this is what we talked about already. I'm not going to spend much time, but you may be encountering patients asking, what about the blood clots? I'm worried about the blood clots, especially if you're young, because mostly in women and also in younger people, that was the incident. So let's go to this one. This is what I tell them. First of all, we give the mRNA vaccine here. I mean, and I'm not going to tell anybody not to take J&J because there was, you know, what is the side effect of an aspirin? How many deaths that happened with aspirin? 1 death in a million. No, 7 blood clots in a million is not a very hugely bad outcome. But of course, we are the medical people. When we talk about it, it sounds like that is the only thing you need to focus on. You need to focus on how effective the vaccine is and how small the outcome, the side effect is. But this is what I say. AstraZeneca vaccine, 4 cases of blood clot in 1 million vaccines. Birth control pills, 500 to 1,200 cases in 1 million women. Smoking, how many of our patients are smoking? 1,763 cases in 1 million. COVID infection, 165,000 cases in 1 million cases. So you have 16.5% rate of blood clots. That's one of the reasons people die in the hospitals. That's one of the reasons people get intubated. Their lungs are full with blood clots, or their brains are full with blood clots. Autopsy studies showed they get strokes and die. So this is the risk for blood clots. And if you can use this analogy to explain to the patients if they ask you that question. Let me go back to the Delta variant, because that's what we're talking about now. This is what we have, what we're dealing with today. And effectiveness of the COVID-19 vaccines, these are recent studies published in New England Journal of Medicine, both of them. I think the left one especially, the effectiveness against the Delta variant. These participants who were partially or fully vaccinated at the time of infection, among the healthcare personnel, this was done, almost 4,000 healthcare personnel and first responders, the people who got the vaccine back in December and January, like most of us, those participants were watched over time. And they were found that when they were vaccinated at the time of infection, when they got the COVID infection, they had 40% lower viral load and 66% lower risk of viral detection more than 1 week. So what that means, you get inside the body less viral load. You might be producing a lot and giving out to people, but then it stays there shorter. So you get over it faster. You're not as sick. And then also 58% lower risk of febrile symptoms and a shorter duration of illness, with approximately 6 fewer days of symptoms and 2 fewer days spent sick in bed than unvaccinated participants. This effect is probably due to a recall of the immunologic memory responses that reduce the viral replication. You have a lot here, but the body says, hey, I am remembering, I got the vaccine, get out of here, and accelerate the elimination of the virally infected cells. So this is the status. total vaccine doses administered. This is September 6th on the left, the world. And then right side is the United States. We have 373,635,560 doses. Now, these are, if that number may confuse you, well, actually, we have half of the population, a little bit more than half of the population fully vaccinated. Those are the doses administered because some of the vaccines are 2 doses. That's why that number is overinflated. I'm switching the gear to the immunocompromised patients and the vaccines. So this is where I become very passionate, and I've been speaking out loud, and I've been talking to you all these months of every month, pleading, please, please, please. And this is why. Influenza vaccine responses are less robust among cancer and transplant patients. Though if we give more vaccines and boosters, they do okay. But it takes more for these patients to be protected than the regular people, immunocompetent people. So you may not have a good response all the way up to 3 months after like a bone marrow transplant. These are old studies. The data, the publications are on the bottom here, 2016, 2020. These are recent data. So this is a known factor. The data on cancer and transplant patients with all these vaccines we have in our hands. Unfortunately, when the studies were done back in last year, only 3.7% of the cancer patients participated in Pfizer trial. And none of these patients were on active chemo or immunosuppression allowed in the trial. So when this vaccine was approved not knowing how the cancer patients are gonna behave. And the Janssen did enroll some patients, but look at the percentage, 0.5%. And only 0.2% were immunocompromised. So when we walked into this back in January, February, March, we didn't know what our patients really did. Look at multiple myeloma. These are a couple examples that were recently published. Of the 92 patients, 52 of them had positive antibody response after the first dose. 52, half of the patients only. And if you look at those, if you can read these with healthy versus multiple myeloma, look how weak it looks on the right graph here. And then when you look at the 48 patients, lower antibody levels were also found compared to the control. Only 12 with response after the first of the vaccine, and this is more than 50% normal that normally happens. And here is another example. You can read these. I'm going to actually put them up there in the slides, but same story. When you had CLL patients, 52% versus 100% response rate, comparing to CLL or chronic lymphocytic leukemia patients versus normal people. So patients with the drugs like BTK inhibitors, these are the drugs that we give in our clinics, venetoclax or antibodies, they had very little response to the vaccine. Well, antibody levels, everybody is so crazy about antibody levels. Here is the thing. Post-vaccine antibody levels not only vary by the vaccine, mRNA being the highest, but also depending on the situation, depending on the response of that person's immune system. It may be active chemo patient, it may be the type of the cancer, it may be their own immunity. There might be variations. This is why when they did the studies, this is from CDC on the right side, post-vaccine serological testing has been performed as part of the clinical trials, but the utility of testing has not been established. I mean, out of curiosity, sometimes I check people and it's all over the place. But what we know, that the underlying immune compromise or therapies disrupt the immune response. And therefore, these are the people that were recommended to get boosters. Dialysis patients, chronic liver disease, hematology oncology patients, immunosuppressive therapies, transplant patients. They are the ones that we are doing the third dose, and thanks for everybody who's participating this weekend's vaccine clinic, and we'll probably be doing more of those. And I'm vaccinating my own patients as much as I can. And if they got Moderna because we don't give Moderna, I tell them to go get it because everybody's confused about this 8 months thing. One last thing about the vaccines and cancer patients, timing of vaccinations. This is all a proof why the cancer patients have lower immunity and what happens to them. Transplant patients, there is even some timing debate. Should we give it 3 months after or 6 months after? Leave them like babies with no vaccination and give them early, but they won't have a response. Should we give it after 6 months? So flu vaccine, for example, now we give it, but after 3 months, but there is some debate even pushing it out a little bit longer. So our current NCCN guidelines in that 3 months post-transplant or after cellular recovery, post-cytotoxic chemo, like all the chemotherapy we give for our patients, and all others give the vaccine whenever possible. Meaning if somebody is going through chemo, we have no choice. Give the vaccine, hope for the best. They are not going to probably have a great response, but that's why they are getting the 3rd dose right now. So this is a study that really impressed upon me, and I wanted to share this with you. 218 patients who tested positive for COVID-19 from March 18 to April 8th at Montefiore Medical Center in New York. 61 patients out of the 218 died from COVID-19. This is a fatality rate of 28% as compared to the overall mortality rate of 5.8% in the US. So highest mortality was for 37% for blood cancers, leukemia, lymphoma, myeloma, except for lung cancer, which was some unusual reason it was 55%. And then solid malignancies mortality rate was 25%. Basically, these are our patients. Colon cancer patients, lung cancer patients, leukemia patients, myeloma patients, prostate, even breast cancer patients. That was the best, 14% in that little group. Now, this may not reflect the thousands of patients study, but it's impressive to me. This is something that I know as a fact, which makes me think when I come to work, how I can protect my patients. So this is another troublesome factor, that these immunocompromised patients, they are hosts of these viral variants. And then what they do, they cannot get rid of these viruses. Therefore, they keep mutating, and they are harboring the possibility of making more mutated and more difficult to treat viruses. So they are not only, they need to be protected, they are also danger to the society, not because they can help it, but they are the ones that will get those viruses. So therefore, 3rd dose mRNA received FDA for immunocompromised. New vaccines are in the pipeline. We still don't know what to do with antibody levels. If you're out of curiosity checking them, don't just depend on it, because there are other things that goes on in that complicated immune system that contributes to the response. And do we need higher doses? We don't know. People are working on it. Do T cells provide sufficient protection? Are those with limited antibody protected? All of this is being researched right now. I will make a big note of this. Now, this is too important not to pass. We made this very no visitor policy. If you remember, we came up last week and we said, not only we're not going to take visitors anymore, all the providers, all the front desk people, everybody should be aware of it. But now we're not even going to take unvaccinated people if they have to bring a caregiver. If we allow them to get a pass, unvaccinated visitors are not allowed. Well, the caregivers make a big difference. So if the simple logic is the fact that these patients are very immunocompromised and may not be responding well to the vaccine, and if they get this very contagious vaccine, sooner or later, they can die from it. Therefore, they should not be exposed to people who are unvaccinated, because unvaccinated people will have a higher load, not higher, longer duration to be transmitting the disease to vaccinated. Plus, they will be sicker from it, and they will cause, they will not protect these individuals at home. For us, medical professionals who are serving immunocompromised people, bringing unvaccinated individuals to our clinic, and any people, vaccinated or unvaccinated. Carrie Ann brought this up in one of our viral illness task force, and I agree with her. If vaccinated people are able to get it so much and produce all these big loads, everybody should be careful anyway. But unvaccinated people have a longer duration and more risk for these people. This is why we recommend not only patients, but their family members to be vaccinated and not allowed in our clinic if they are not vaccinated. So I'll show you some statistics before I finish. As of September 1st, this is what Washington State is doing. This is a 7-day average, and we are a red state. That means very high rate of infection rate. And if you look, there was these big blips in around, if you remember, Thanksgiving and Christmas. We're actually probably surpassing that. You'll see that by hospitalizations. And there has not been a time since the beginning that we had this many hospitalizations in our Pierce County. This is in the Washington State. It is the death counts. Look at the death counts, how they are increasing over time. And this is our county. Our county is, what happens if you look at this is a very interesting graph. If you can spend a minute to look at this. October, November, December, that Christmas, Thanksgiving time, infections peaked and the death increased after that peaked. Not immediately, not in the same line. So now the infections are peaking even more and the deaths are just starting. So I am expecting more deaths coming, and I think it's going to surpass that time in January and February or in December, unfortunately. So this is what we expect. The scientists expect. I got this from Dr. Steve Pergam. Vaccinated cancer patients will continue to develop COVID-19, become hospitalized, and may die from SARS-CoV-2. Most of us will be fine because we're vaccinated, but not our patients. Decreased community levels will decrease risk, but regression to poor vaccine coverage will assure it remains in our communities. This is not going anywhere because we haven't achieved that great rate of vaccination in our country. And similar to H1N1, this will become a continuing issue. It's not going anywhere. And expect a yearly vaccine for all of us and for our patients. These are from Dr. Steve Pergam, who's the head of the immunology department at the Fred Hutchinson. So here is some, I will wear my mask here or there. I will social distance everywhere. Since the vaccine may not be as effective in immunocompromised patients, we are the caregivers. We are the medical professionals. We are burning out. We are demoralized. We are angry. We're dissatisfied. We want to help, but yet our hands are tied because we fear for even our own families and ourselves. So what we need to know is that we wear a mask in public spaces, even if other people don't. Even outside when you're in a crowd. Avoid the crowds. This is not the time to go big parties. And if you have to be extremely cautious and stay away from at least symptomatic people, but know that there will be asymptomatic people that are COVID positive in that group. So be alert on that. The third vaccine, if Moderna or Pfizer for the first one, I really wish that they could do something for J&J patients because we have a lot of them. Wear a mask in enclosed spaces for sure, that goes without saying. Avoid inside visits with family, friends if they do not have close contact with you already. I mean, I'm talking to you guys, not just the family patients. This is the time to do it. And if you have to come together, test them. I did that on the past weekend when we had a small gathering for my mother-in-law's 80th birthday. Everybody got tested before they came in, and everybody were careful days before coming in. And we did it outside, and people wore masks unless they were sitting down and eating. Just be extremely cautious. All caregivers and close contacts should be vaccinated. That's for us, for our patient population. I'm not going to go and tell other families out there, although I kind of am sometimes, but it's for our patients. tell them, if you run into them, if their family members are not vaccinated, encourage them. And there is some hope. There is monoclonal antibodies that's actually approved for the treatment of mild to moderate coronavirus disease 2019, COVID-19 in adult and pediatric patients. Dr. Agatzia was asking me this question. It is available at certain places. We're not doing it yet, but we're going to be looking into it. Our infectious disease partners, all partners at CHI, they do it. If you have a patient, leukemia, lymphoma, myeloma, somebody transplant, they really are the high risk group. But if somebody, this is even for prophylaxis, it's not approved yet for prophylaxis, but if somebody in that capacity had a post-exposure, exposed to someone who's COVID positive, they are at high risk for progression to severe COVID-19. They could get these treatments. So in conclusion, we are at the worst time for COVID since the pandemic started, but effective vaccines are available, still beating those bad viruses to make us very sick. But infection rate is high and it's going higher. And our immunocompromised patients are at risk. They are just, I hope I gave that message. I said it a few times only, but they are more vulnerable and they are at risk of dying, even though we will probably be okay. The current Good Samaritan Hospital inpatient COVID rate for unvaccinated people is 95%. So that means 5% are in the hospital, they are vaccinated. And I bet you some of those are very high-risk people. If there is a known exposure to COVID, please call your doctor immediately for REGEN-COV and monoclonal antibody combination. This is for the patients. I'm saying this for the patients if it is presented up there. We, as physicians at Northwest and APPs, will know that. But if you're not exposed to us, if you don't see us all the time, call your doctor if you're at risk, if you're a high-risk person, because there is a monoclonal antibody for those people. And with this, I'm going to finish, and I thank you all for listening in this late afternoon for you, late evening for me. It's 8:46 in Indiana. But thank you very much.